A woman is dying. It's 1879. She's in labor somewhere in the kingdom of Bunyoro, in what is now Uganda, and the baby will not come. The only procedure that can save her is a Cesarean section. And in 1879, that is its own kind of death sentence. In European hospitals at this very moment, 75 to 85% of mothers who go under the knife for a C-section don't make it. The surgery is so dangerous that most European doctors won't even attempt it on a living woman. They wait until she dies, then try to save the baby. That is the state of the world's most advanced medicine in 1879. But this woman is not in a European hospital. And this story doesn't end the way Europe would expect. What happens next is something that, by every assumption Europe held about Africa in 1879, should have been impossible. A British medical missionary named Robert William Felkin, trained in European medicine, is about to witness a surgery that will shake everything he thought he knew. Not because it went wrong, because it went right. More right than anything he had been trained to believe was possible on this continent. We're going to come back to that operating room, to that surgeon, to that woman and what happened to her. But to understand how that surgery was possible, what tradition produced it, where that knowledge came from, how deep those roots actually ran, we have to go back. Not just to 1879, much further than that. Go back 10,000 years, maybe more. Someone in Africa opened a human skull and the patient survived. We know this because of what bone does when you live. When you drill or scrape through a skull, a procedure called trepanation, the bone around the opening heals if the patient survives long enough. The edges smooth, new bone grows. That signature cannot be faked or misread. The skull found, the healed margin present, means one thing: surgery was performed and the person who received it went on living. Trepanation appears in the archaeological record on multiple continents, but some of the oldest evidence comes from Africa. Skulls bearing the unmistakable marks of successful brain surgery, dating back at least 7,000 years. And what makes the African story distinct isn't just the age of these skulls, it's what happened next. This knowledge didn't vanish into prehistory, it was carried forward. In 1957, Kenya's government psychiatrist traveled to the Kisii highlands of Western Kenya. Edward Margetts was there to investigate reports of something that, by the 20th century, should no longer exist: practitioners performing skull surgery. Not in hospitals, not with instruments imported from Europe, with tools they had made, using techniques they had been taught, in a tradition that stretched back further than any institution he had trained in. The procedure was called craniotomy. The primary indication was head trauma. A man falls, a blow to the skull, persistent headaches that won't resolve. The surgeon would use a hooked knife to carefully scrape away damaged bone, working gradually to avoid piercing the membrane beneath. The dura mater, which when breached, carries significant risk of death. The patient remained conscious. Not because these surgeons lacked compassion, but because localized plant-based anesthetics were sufficient and safer. Keeping the patient awake also allowed real-time monitoring of neurological response. By the early 1980s, researchers documented over 100 active practitioners in the Kisii region performing these operations. The missionary John Roscoe, documenting Busoga medical practices in 1921, wrote, "The surgeons, therefore, get much practice in this kind of work, and they have learned how to remove splinters of bone from the brain and thus restore men, who would otherwise die or live insane, to life and reason." Every researcher who studied these traditions came back with reports that they worked. The mortality rate for Kisii craniotomy was approximately 5%. 5%. For a surgical procedure opening the human skull, performed without modern anesthesia, antibiotics, or sterile operating rooms. For context, modern neurosurgery in well-equipped hospitals today carries mortality rates between 3 and 7% depending on the procedure. Think carefully about what that represents. A surgical technique developed thousands of years ago, transmitted across millennia through oral tradition, still being practiced successfully in the 20th century. When European archaeologists uncovered ancient trepan skulls and identified them as evidence of early human ingenuity, the response was celebration, evidence of the human capacity for medical innovation. When those same researchers encountered Kisii practitioners in the 1950s, Performing the same surgery with documented success, the word used was primitive. Same surgery, same evidence of survival, different verdict, based not on the medicine but on who was performing it. And when colonial authorities decided that verdict needed enforcement, they moved from dismissal to prohibition. In 1958, a Kisii practitioner named Nia Chuba Umbadi was brought before Her Majesty's Court of Appeal for Eastern Africa. The charge: practicing medicine without a license. His charge was moved from murder to manslaughter, from a healer to a criminal. These practitioners had no ill intent, that they were doing what they had been trained to do, what their communities trusted them to do, what the evidence showed they could do successfully. Margits was photographing patients and documenting surgical techniques in clinical detail. Nyachuba was sitting in a colonial prison for practicing the same tradition. That was 1958, the same year, the same highlands. Extract the knowledge, erase the source. Now move forward in time, but not forward in the way you might expect. Because the next story doesn't start in a hospital or a laboratory, it starts in chains. Sometime in the early 1700s, a man was taken from West Africa, enslaved, and transported across the Atlantic to the colony of Massachusetts. His name was Onesimus. He was purchased by Cotton Mather, a prominent Puritan minister in Boston, and he carried with him, in his memory, something that would one day save hundreds of American lives. In 1716, Mather asked Onesimus a simple question: had he ever had smallpox? The answer he received changed American medical history. Onesimus told him yes and no. As a child in West Africa, he had been deliberately given smallpox. A small amount of material from a pustule had been introduced into a cut made in his skin. He developed a mild case, recovered, and from that point forward was immune. He would never get the deadly version of the disease. And he was not alone. This was a practice his community had used for generations. Think about what that practice required. Somebody, generations before Onesimus was born, had to observe that survivors of smallpox never got it again. Then somebody had to make the leap. Deliberate exposure to a mild case might confer the same protection. Then a community had to trust that idea enough to test it on their children. Then practitioners had to refine the dosage, the method, the timing, until it worked reliably enough that parents weren't gambling with their children's lives. They were protecting them. That is not folk wisdom. That is medical science that simply didn't write its findings in a language Europe recognized. Mather was skeptical at first, but Boston was deep in the shadow of recurring smallpox epidemics, and in 1721, one arrived with particular force. People were dying. Fear was spreading faster than the disease. And Mather, desperate, found a physician willing to try what Onesimus had described. Dr. Zabdiel Boylston began with the people closest to him, his own 6-year-old son and 2 enslaved men in his household. All 3 were inoculated. All 3 developed mild cases. All 3 recovered and were never susceptible to smallpox again. Over the course of that 1721 epidemic, Boylston inoculated 287 people. 6 died. That's a mortality rate of roughly 2%. Among Bostonians who contracted smallpox naturally, without inoculation, the death rate was 14%. The numbers were not ambiguous. The West African medical practice that Onesimus had carried across the ocean in his memory was saving lives in colonial Boston at a rate that European medicine couldn't touch. 1 in 7 died without it, 1 in 40 with it, almost 6 times safer. But the idea was met with fierce resistance. The New England Courant, Boston's first independent newspaper, was founded specifically to attack Mather and Boylston. The same prejudices that made Mather distrust his enslaved servant made other white colonists unwilling to accept medical knowledge from an African. African medicine was assumed to be primitive at best, poisonous conspiracy at worst. The data eventually won. By 1749, even William Douglas, the most vocal opponent of inoculation, published an essay admitting its benefits and encouraging its adoption. The story of vaccination as mainstream history tells it begins with Edward Jenner in 1796 as a foundational figure in immunology. His work was genuinely important, but variolation, the deliberate induction of smallpox immunity, was being practiced in West Africa generations before Jenner was born. It reached America through an enslaved man. It was proven effective in Boston 75 years before Jenner's experiment. And in the standard account of medical history, the West African origin of this knowledge is either a footnote or absent entirely. The knowledge crossed an ocean. The credit did not. If you're learning something here, share this with someone who needs to hear it. Also, subscribe so you don't miss the next episode. Now we go back to that operating room, back to 1879, back to the woman who was dying. In European hospitals of that era, attempting a cesarean section on a living woman was so dangerous that the medical community actively debated whether it should even be done. Joseph Lister had been promoting antiseptic surgery since the 1860s. The revolutionary idea that invisible organisms caused infection and that surgeons should wash their hands, sterilize instruments, and stop operating in their street clothes covered in blood from previous patients. The European medical establishment had spent the better part of 2 decades mocking him for it. That was European surgery in 1879. That was its state of the art. Now here is what Falcon documented in his account published in the Edinburgh Medical Journal in 1884. The surgeon first gave the woman banana wine, enough to dull the pain and calm her body. Then he did something that European surgeons were still arguing about. He washed his hands and her abdomen thoroughly with banana wine. The incision was precise, midline, controlled. He cauterized the bleeding with a red-hot iron, delivered the baby and massaged the uterus to stimulate contraction and reduce post-delivery bleeding, a technique that wouldn't be standard in European obstetrics for years. He closed the wound with 7 iron pins and applied a paste made from medicinal roots. Falcon watched all of this, and he wrote, "The operation was cleanly and rapidly performed. The technique indicated a well-established practice handed down through generations." These were the words of a trained European doctor recognizing expertise. The woman was conscious and nursing her baby within 2 hours of the surgery. Within 11 days, she had fully recovered. Both mother and child survived. The doctors of the isolated Bunyoro kingdom did not learn this technique from outsiders. The first Europeans arrived in 1862. This was indigenous medical knowledge, developed independently, refined across generations. And the Bunyoro medical tradition extended beyond surgery. They practiced protective inoculation against endemic syphilis in children. The British physician F.J. Lambkin reported in 1903 that the people of Bunyoro inoculated infants to prevent a repetition of the disease in grown-up life. This practice was widely accepted and done purely for medical reasons. Falcon published his account in European medical journals. It was read, and then it was largely set aside, because acknowledging it meant acknowledging something that the entire colonial project was built on denying: that African medicine was sophisticated, that African surgeons had solved problems European surgeons were still dying to figure out, that the people Europeans were colonizing, subjugating, and classifying as primitive had developed medical practices more effective than those of their colonizers. That acknowledgement never came. The surgery in Bunyoro was filed away as an interesting anomaly, a curiosity, a footnote, and European obstetrics continued killing mothers at catastrophic rates while maintaining that it was the only real medicine on Earth. 3 stories, 3 moments where African medical knowledge met European judgment. A surgical tradition carried forward across 10,000 years in East Africa produces practitioners still operating successfully in the 20th century with a 5% mortality rate, and colonial courts imprison them while researchers document their techniques. An enslaved man's childhood memory from West Africa saves a city in 1721, cutting smallpox mortality from 1 in 7 to 1 in 40. 75 years later, a European physician receives history's credit for vaccination. A surgeon in Bunyoro performs a cesarean section in 1879 with outcomes European medicine couldn't match. The account is published, read by the medical establishment, and set aside while European hospitals continue killing mothers at rates 7 to 8 times higher. This is the history that doesn't make it into the standard account. Not because the evidence is absent, it's there. In Falcon's published journal article in the Edinburgh Medical Journal, in Cotton Mather's correspondence with the Royal Society, in Marget's clinical photographs and published papers, in John Roscoe's ethnographic records of Busoga, in archaeological sites across the continent. The evidence has always been there, but the standard account was never built to contain it. It was built to tell a different story. A story about who creates knowledge and who receives it, about who has history and who is simply waiting to be found by it. The evidence doesn't support that story. It never did. What it supports is this: the history of human medicine is not a straight line running from Greece to Europe to the modern hospital. It is a global accumulation of observation, of practice, of knowledge carried forward in forms that don't always look like textbooks, but work exactly like them. And running through that accumulation, deep and undeniable, is Africa. The knowledge was always there. What was missing was anyone willing to look at it honestly. This is part of a series on pre-colonial African achievements. If this history matters to you, subscribe so you don't miss the next episode. See you on the next one.